This is a video I try to demonstrate how I operate on a white milky cataract. The video is minimally edited, but I have speed up the video to minimize the viewing time. After creating the main incision and paracentesis, vision blue is then injected into the anterior chamber. Keep the vision blue for about 15 to 20 seconds, then use viscoelastic to push out the vision blue. You can use any type of viscoelastic, but try not to use methyl cellulose. Then use a 26 or 27 millimeter, go through directly through the main incision, and then try to puncture the anterior capsule and straight away aspirate the whatever liquefied cortex to reduce the intracapsular tension to prevent Argentina flag sign. And then this is followed by using a capsulorhexis forceps to create a CCC. Try not to make a CC too large at the beginning because there is still risk of extension of capsulorhexis if you are not careful. For beginner, try not to use methyl cellulose to tamponade the anterior chamber because it tends to leak out easily and the AZ will become shallow and the rhexis will tend to extend easier. For a white and milky cataract like this, hydrodissection is not necessary because most of the time the nucleus plate is small and it's mobile, so you can just straight go in and perform the phaco emulsification. And again, the difficult part when it comes to this surgery is the capsulorhexis. As you can see here, the nucleus is actually very brittle, very easy to crack, and not difficult to emulsify. So the subsequent surgery is actually quite easy compared to a Brunnerson cataract. So here I'm showing you bit by bit. I'm chopping off the nucleus and emulsify it. So as you can see, the nucleus is easily chopped without much difficulties. So when it comes to the last piece, again, try to be careful. Perhaps this is the stage where you still can continue with the same setting, but when it comes to the last piece, I tend to use a lower vacuum from 450, which is my usual vacuum, cut down to 250 millimeter mercury. This is followed by a normal INA of the cortex using a curved INA tip. Viscoelastic is then injected into the anterior chamber, deepen the back. IOL is then implanted, and the eye is rotate and down into the back. The viscoelastic is then aspirated from the front part of the lens. Wound is secure by hydrating with BSS. Lens is pushed away, and then the viscoelastic behind the IOL is washed away, and the case is concluded. Thank you for your viewing.